she has just done amazing work in research in stroke for all these years. This morning, she's going to actually talk about sex differences in stroke and give us an update review. So, Dr. Bushnell, thank you very much for coming to join us this morning.
Thanks, Rayetta, for that introduction, and it's always a pleasure to be at this conference, to see so many people interested in the topic of stroke, getting education, and we'll do our best to try to make this a worthwhile day for you. And we'll start off with talking about sex differences. And what I want to do after I tell you about my disclosures is really walk you through the latest evidence that we have for sex differences in stroke. And what I want to talk about is what are the actual differences, and then what are the differences that are really clinically important, and how does that impact our practice. And I came from the World Stroke Congress in October in Montreal, and there was a whole session on sex differences, and I feel like I've been completely educated, and I want to share that with you. It is the latest and greatest update that we have on sex differences and how to read the literature. So that's really what I want you to go away with today. So I'm going to define sex, gender, and then a new concept that sex is a biological variable, and this is important for research. But I just want to let you know that it's out there and it's driving how research is being designed. And then define how sex differences should be studied and reported, and this is also coming from the National Institutes of Health. And then I'm going to talk specifically about sex differences in risk factors, treatment, and outcomes. And I'll do that, basically walk you through a review article that we published in Lancet Neurology earlier this year. And that's going to deal with pre-hospital and the ED evaluation of stroke, the signs and symptoms and stroke mimics, imaging times, eligibility for and receipt of IV TPA, and then outcomes after TPA and endovascular treatment. So this is a picture of somebody who's doing something really, really brave. And this is actually from Norway. This is outside of Bergen. And on the surface, this looks like a pretty terrifying position to be in. And that's kind of where we are with sex differences, is that it's a really steep climb, right? But the good news is that you can't see this, but this guy is a climber. He's actually got ropes. And so if I were to zoom in on this guy, he's got ropes that go from the very top here and all the way down. And actually, it's ocean right down here, and very cold ocean below him. So what we really want to pay attention to is the fact that we actually do have some ropes that are helping us climb out of this really difficult issue of understanding sex differences. And hopefully we can illustrate that for you in data as we go through this talk. So what is the difference between sex and gender? And this is something that you'll hear often, and a lot of people prefer to say gender over sex, but I really want to emphasize where the two terms are truly important and different. So sex originates from an organism's sex chromosome complement, so XX or XY, and it's reflected in the reproductive organs. And it really is driving physiological function and behavior. And then gender pertains to social, cultural, and psychological traits linked to human males and females through social contacts. And a lot of times, this is where that comes in, because somebody may be born with one sex and then identifies with the other. So this is where sex and gender differentiate. And now sex as a biological variable is really the other thing I want to mention along this line. And the NIH has decided that expectation is that scientists will account for the possible role of sex as a biological variable in vertebrate animal and human studies for applications starting in 2016. So this is a very recent change. And I reviewed for NIH recently, and it's clear that a lot of the people writing grants don't quite understand this just yet. It's still kind of making its way into the culture of how we design and research. So why is this important? Because sex and gender both impact health and disease in very significant ways. And consideration of sex and gender in research informs development and testing of prevention, therapeutic interventions that are going to help both sexes, both men and women. And then women account for roughly half of all participants in NIH-supported research. It's not always been that way, but yet a lot of the preclinical studies were done with just male animals. And so there are a lot of things that were missed in the translation from the bench side of research into the clinical side. So this is really important and part of the reason that NIH has mandated this change. And then sex as a biological variable addresses how males and females are both similar and different. And this is also important for therapy and clinical policy. So I'll talk now about stroke in particular and where we are. So what do we mean by a sex difference? And I want to acknowledge Matt Reeves, who is an epidemiologist at Michigan State, for letting me use his slides because he presented this in Montreal last month. And I just thought this was the best kind of approach to explaining sex differences in stroke, and hopefully you all will come away with a good understanding. So what is a sex difference? It means any difference in an outcome or trait between men and women. The precision of that difference should be sufficient to be deemed reliable. That's a reliable difference that you can see from study to study. And the magnitude, or how different they are, it's the measured difference that should be large enough to be of clinical importance. So that's the other really important piece. And then the outcome or trait should be common enough to be of potential public health importance. In other words, this is really important at a population level. So a lot of times you might see crude sex differences and adjusted sex differences. So a crude sex difference is just what is the direct comparison between men and women on a trait or an outcome. So that's just like a mean difference in age, for example, would be a crude difference, or a difference in disability between men and women. And then it doesn't account for anything else. So it's just that absolute comparison between men and women. So an example here is the 28-day case fatality rate of 29% in women versus 22.7% in men, and that is a relative risk of 1.28. So that's the crude difference between men and women. And then they're relevant because they're lived experiences between men and women. They're important in their own right. But they may not be important from a clinical or a policy standpoint, and that's because the difference may be reflecting confounding or other factors that are actually driving that difference in the crude sense. So sex is not the cause, but it could be a marker of something else. And so I'll kind of give you some examples. A crude sex difference adjusts for some factor that we think could be acting as a confounder. And so if we're doing an analysis and we see that this difference changes by a certain percent, and the rule of thumb is 5 or greater than 10%, change in that estimate means that there's confounding, that something else is explaining this difference between men and women. And if it remains, if there's still a sex difference after you account for that variable, then you have the statement that sex is independent from that other variable. And I'll give you some examples of this. But either way, the results of statistical adjustment might indicate a possible mechanism behind the sex difference, and it might provide some clues to interventions that could ameliorate the sex difference. And so here's an example that's incredibly important: age. So women have a higher risk of one-year mortality following stroke than men, with a crude difference of 35% versus 24%, with an odds ratio of 1.6, so a 60% difference. Now, women are older than men, with a mean age of 77 versus 72. So age is an important predictor of mortality, and women happen to be older than men, and therefore there's a mortality difference. And so if you adjusted for age, you would actually see that that difference between men and women in mortality goes away. So you have to adjust for age if you're going to look at something like mortality. And the same thing for stroke severity. So women on the surface may have a difference in stroke severity compared to men, but women are older, and older people have more severe strokes, okay? It's the same concept. Now, here we're seeing an unadjusted difference. This is just showing you what odds ratios look like. So you have an odds ratio of 1.6, and what this means is that there's a 64% increase in mortality compared to men and women. And then when you adjust for age, here it decreases from 1.64 to 1.30. So a 30% attenuation or 30% minimization of the difference, but it's still statistically significant. And so the interpretation of this is that that change in the adjusted odds ratio here of 1.3 is that after adjustment for age, there's definitely strong confounding. So age had a huge impact on this difference between men and women. So those are the two odds ratios that we're paying attention to. Now this is a wonderful review by Linda Elizabeth at University of Michigan, along with Matt Reeves at Michigan State. And they actually looked at all of the adjustments that you can make to understand the differences between men and women. And it's hard to read, but I'll just tell you that this first, here are these two dots in wildly different directions. And this is for the variable of pre-stroke modified Rankin score. So this is what is the level of function prior to a stroke occurring. And the difference between men and women is huge. So what that means is that women are more likely to have poor function prior to the stroke onset, okay? And so this difference varies then along the different variables, and I'll tell you that one of them is comorbidity index. That's the second circle here, showing the difference between men and women. And then pre-stroke nursing home residents, also a big difference between men and women. And then a history of stroke or TIA and coronary artery disease. And then as you get along the variables here, there's really no adjustment difference that occurs when you look at men and women. So really it's pre-stroke function and pre-stroke comorbidity that has a huge driving factor in living status, and those are some of the things that can really impact your ability to find sex differences. So those are the confounds that we talked about. And then there's effect modification or interaction that you may see in the literature. And what this means is that does a risk factor have a differential effect on stroke risk in men versus women? And I'll show you some illustrations of this next. But these are the two risk factors that really do differ between men and women. It's diabetes and atrial fibrillation. And does a treatment or intervention have different efficacy? Does it work better in men versus women? And when we look at that, that's a treatment by sex subgroup analysis. So this is, after the study is done, you take the two variables of treatment and sex, and you see if there's a difference in effect between the two. And that's been shown at times in aspirin use, in carotid endarterectomy, and also in TPA. And I'll talk about that later as well. But most studies are not powered. What that means is that they aren't large enough to show a statistical difference in treatment by sex and interaction. And so most of the interactions that you might see in the literature are actually probably false positive findings. If you analyze everything under the sun in a small group of people, you might find something, but does that really mean that it's significant? And so there can be things that happen by chance, and that's really what they're driving at here. It highlights the need for replication So you have to do another study in another population, find the same thing, and then you might start to believe that that's maybe a true finding. Or you put together multiple studies and you do a meta-analysis. So this is another really powerful way of understanding whether there are interaction differences or sex differences. And actually what I'm going to show you coming up now is the power of these meta-analyses in illustrating the differences between men and women in stroke risk with atrial fibrillation and diabetes. And so this is a typical forest plot that you'll see in a meta-analysis. And what it shows here on the right-hand side is the relative risk of having a stroke in the setting of atrial fibrillation. This is men only, and this line here is 1. And so anything to the right of 1 that doesn't cross this line is considered significant. So you can see that there are several studies here where the line doesn't cross 1, and if you add up all the studies together, you get an odds ratio or relative risk of 1.77. What that means is that there's a 77% increased chance of having a stroke with atrial fibrillation compared to men without atrial fibrillation, okay? So this is what this summary odds ratio is showing you here, or relative risk. I may flip back and forth between the two. Now here's women. So you have almost no crossing of this line here of 1, and you have a summary odds ratio or relative risk of 4. So 4-fold increased risk of stroke in atrial fibrillation in a woman with atrial fibrillation versus no atrial fibrillation. So you had a 70% increase chance in men and a 400% increased chance in women. So it's a pretty big difference. And if you look at the ratio of that, it's almost twofold, right? Okay, so women with atrial fibrillation, high risk of stroke. We knew that, but it's probably much higher than it is in men. Now, if we look at diabetes, here's another meta-analysis. And again, this is just looking at the women to men ratio. So this is actually taking both genders and looking at the studies that showed women had a higher incidence of stroke with atrial fibrillation than men, or sorry, with diabetes than men, okay? So now what you have is, if you compare women to men, with the risk of stroke with AFib is 30% higher in women compared to men with diabetes, okay? Does that make sense to everyone? I'm happy to, just raise your hand if you have a question as we go along. But this is just to illustrate that, again, like atrial fibrillation, there is an increased risk of stroke with diabetes in women compared to men. And it's less in magnitude than atrial fibrillation, but it's definitely significant. Okay. So the same types of meta-analyses have been published for a variety of risk factors, including blood pressure, cholesterol, and smoking. And when you look at those meta-analyses, there's really no significant difference in men versus women, okay? So that work has, I'm just summarizing loads and loads of work into one line of my presentation, but just to say that there's really no significant difference. The two risk factors that are important are diabetes, with women having a 30% higher risk of stroke, and double the risk of stroke, or 200%, with atrial fibrillation in women versus men. Now, there are multiple kind of descriptive sex differences that we can talk about related to stroke, and I'll go into that next. And the other thing to really know from a neuroanatomical standpoint is that the brain is sexually dimorphic. And what that means is there have been descriptions of how the brain volume may be larger in men, but when you control for the total volume, women actually have a higher percent of gray matter. And then global cerebral blood flow is actually higher in women, and sex-specific differences have been found in dopamine pathways, serotonin pathways, GABA pathways, and it suggests that male and female brains are neurochemically different. Duh, right? So these are descriptive differences that have done. A lot of the studies were done with functional MRI, some of them done with pathologic studies, but that's just sort of a summary of the literature. Now, what does that really mean? We're going to talk more specifically about stroke, but I don't think that there's any doubt that men have a higher stroke incidence than women. But women have a 20% lifetime prevalence of stroke versus 17% in men, and that's because they live longer. Okay, so you live longer, you're more likely to have a stroke before you die. About 30,000 more women die from stroke than men, and stroke is the 5th leading cause of death in men, but it's either 3rd or 4th leading cause of death in women, depending on which source you read, and that again has to do with age. And there are 200,000 more disabled women. If you take the population of women living with stroke, there's going to be 200,000 more disabled women with stroke than men. So that's just kind of the crude differences that we described earlier. And what are some of the reasons for these differences? Women have been shown to have smaller arteries, and therefore they may have smaller clots that could be lysed by TPA more easily. So some of the crude differences are that women respond better to TPA than men. Women are more likely to have atrial fibrillation, as we talked about earlier. And if a stroke is caused by atrial fibrillation, it's involving fibrin-rich clots, and TPA is attacking fibrin. It's fibrinolysis. And then men are more likely to smoke, which increases the fibrinogen levels and platelet aggregation. And so some of the thought is that women, if they're less likely to be smokers, will have less fibrinogen and the clot will lyse easier. And then men have higher hemorrhagic conversion or medical complications after stroke. So this is probably based on just a few studies, and I'm not sure that this has been shown universally. It's just been suggested that men may have higher hemorrhagic conversion. Well, back in 2008, Matt Reeves and I and a group of interested authors, co-authors, were looking at a review of sex differences. And this was something that we put together based on a presentation at the International Stroke Conference. And so we went through the literature. We published this in Lancet Neurology. And then Lancet Neurology came to me and said, we'd like you to update that review that you did back in 2008. And so we did. They put us in a little bit of a difficult spot because they said, we don't want you to cite anything that was published before 2008. So we can't use the foundation of some of that literature in this new review. So just so you all know that this is 2009 and forward in the data that I'm going to show you. And what we did was focus on the evaluation and treatment of acute ischemic stroke. So this is what I'll walk you through here in a moment. So we wanted to look at the pre-hospital activation of EMS, symptoms and signs, and stroke mimics, diagnostic imaging, and time to acute brain imaging. So I'm going to focus on just that portion of the acute stroke evaluation first. So in terms of EMS, there were 12 studies that were published since 2009 around the world. 7 of them were designed specifically to examine sex differences. That was one of the things we pointed out, because sometimes there's a post hoc look at data and they just say, well, this was the difference by sex. And some of these studies were actually designed to look for sex differences. But only 4 of them actually found a sex difference in the use of EMS. None of them adjusted for age, stroke severity, or pre-stroke function. So I've already showed you that those are the things that typically will confound the difference that you're looking at for sex differences, or the change that you might see. The limitations, again, are that these are a wide range of populations, and that there was a wide range of the number of patients utilizing EMS in different countries. So China, for example, they're less likely to use EMS compared to the US. Now, in terms of sex differences in presentation, women are more likely to have non-traditional symptoms. And this is really important because it can delay the evaluation of women who might have a stroke in the emergency department. So women are more likely to have pain, they're more likely to have changes in their level of consciousness, and they're more likely to have these non-specific symptoms, sometimes associated with generalized weakness. And this is sort of the summary of the studies that have looked at it, and I'm going to kind of point out the prevalence of non-traditional stroke signs and symptoms, and I'm going to enlarge it here so you can maybe actually read it. But for one study, the way they reported it was that the adjusted odds ratio for having at least one non-traditional stroke symptom was 1.42, so a 42% increase in non-traditional stroke symptoms in women versus men. And they also noted that just if you looked at mental status change, there's definitely a higher proportion of women who have this, 23%, versus 15% of men. So that was statistically significant, okay? And then the next one looked at defining non-traditional stroke symptoms as a somatic cluster. And so that included, pain, mental status change, generalized weakness, fainting, et cetera. So the somatic cluster higher in women, 73% versus 65% of men. And then loss of consciousness, 31% in women versus 23% in men. Incontinence, again, sort of more of a non-specific symptom, 22% in women, 17% in men. And then generalized weakness here you can see is higher in women. Fatigue is higher. Mental status change is higher. Now, those are all potentially relatively valid stroke symptoms. It's just that they may fool you in the emergency department. So this is why it's still important to, if somebody has an acute onset of a symptom, to really be thinking, could this be a stroke, and am I going to miss a stroke here, because we don't want to miss the opportunity to treat people. So the limitations of the study of stroke symptoms is that many of them didn't adjust for stroke or for age or stroke type. So stroke type could influence the type of symptoms that you're going to see. And then none of them adjusted for comorbidities, psychiatric diagnosis, which can really make it difficult to figure out what's going on in the emergency department, pre-stroke function, and dementia. Dementia is really huge. I mean, we see this in the ED all the time. Somebody comes from a nursing home, has dementia, they have a change, but how can you tell what is the dementia and what might be a new stroke? So this is something that we see pretty frequently. Now, stroke mimics, this is really interesting, and there are a number of different mimics that we see, and one of the most common ones is complicated migraines. So somebody might have visual changes, they might have numbness, they might have difficulty speaking, and all of this in the setting of a migraine could certainly be just related to the migraine. And the unfortunate thing is if we assume that rather than really kind of evaluating them as if they might have a stroke too. Seizures can look like migraine. So if somebody has a history of a stroke, they have a seizure, they could have a Todd's paralysis, they have reactivation of the stroke symptom, and they look like they're having a new stroke. A brain tumor can also present like a stroke as they have an acute increase in edema. Metabolic disturbances, so what's the most common metabolic disturbance that we have to rule out when we're looking at acute stroke patients? Anybody? Blood sugar, yay. Hypoglycemia can look like a stroke. And also hyponatremia and hypernatremia are things that we really want to make sure we've ruled out. Spinal cord lesions could potentially look like a stroke. Psychiatric conditions, multiple sclerosis, and stroke reactivation, as I mentioned earlier. So these are the studies that have been done to examine sex differences in stroke mimics. The first study was from Finland, and they only had a small number of mimics to start with, only 14, but 79% of them are women. They didn't necessarily do any statistics for that because it was such a small sample. But then here, when you have larger samples, you have 33% women, 56% 68% in this last study, and these are all statistically significant. So I think that it's pretty convincing with larger studies that you're going to have a larger presentation of stroke mimics in women. But this kind of goes along with the non-traditional symptoms that we talked about in the previous topic. And now we're going to talk about door to imaging times. And here's another really important metric that Joint Commission looks at. It's a core quality measure to get timely imaging of acute stroke patients. Delays can be a major reason for a delay in treatment. And so what we see here in this red box is that and all of these studies measure door to imaging times in slightly different ways. Some of them use the core measure of 25 minutes, yes or no. Others just look at the median or mean door to imaging time. But the bottom line is that the majority of these studies actually do show that there's a delay in women versus men for getting the imaging done. So this is a blown up version of that same thing. And you can see here, this one was not significant at the top. The next one was highly significant, as well as several of these going down the line. But it's really kind of a mixed bag, but more studies than not showing a delay in imaging between men and women. So the limitations are that most of those studies were not designed to study sex differences. The settings were usually stroke centers and not kind of community settings. There was a lack of measurement of the emergency department evaluation and physical exam findings that could impact this decision to order imaging in the first place. And a lot of times what we find when we're examining our door to imaging or door to needle delays in the ED, we'll find that many times it was something else that kind of distracted the emergency department. They were working up chest pain, or they were working up shortness of breath, and then meantime they really were having stroke symptoms at the same time, and that wasn't recognized right away. And then other medical issues, well, I guess I just said what I was putting on the next bullet here. So sex and eligibility for IV TPA. There's a concern that maybe women might have less access to TPA. And we are interested in, one way of looking at it is to study the exclusions for IV TPA by sex. And what this study found from the Greater Northern Kentucky Cincinnati stroke study is that the eligibility for TPA was similar in men versus women after you adjust for age, another important adjustment that they did. But women were more likely to have severe hypertension and have 2 of the 5 ECAS 3 exclusions for that later time window. So this is, again, an important crude difference between men and women. And then the undertreatment of hypertension was one of the things that this study highlighted, and it could contribute to a sex difference in receiving IV TPA. Now, if you look at our review, we found that there are several studies showing that black women may arrive later than white women, black men and white men. So that is another factor that could delay eligibility because of the timing. And then premorbid function could exclude more women, although that's not actually a contraindication. So these days, if somebody walks with a walker or comes from a nursing home, they're still eligible for TPA. Okay, really important point. And then a lot of the limitations of these studies is the fact that, again, they're not looking at the nuanced physician decision-making that occurs in the acute evaluation phase. So now we're going to talk about IV TPA use and door-to-needle times. And so recent studies showed that there's really no clinically relevant differences in men and women getting IV TPA. And for some studies, the lower treatment rates was explained by the later arrival, and that therefore they're out of the window. So the limitations are that there's no adequate adjustment for confounders, so again, age, comorbidities, and some of those studies weren't designed to study sex differences. And then a lot of these studies they're hard to compare because they may have different designs and approaches. So it's kind of apples and oranges type of problem. But door-to-needle times generally, thankfully, are similar between men and women. We didn't find any major delays. There can be slight delays if you look at a really, really large data set, like Get With the Guidelines. Here you're comparing 1 million men to 1 million women, and a slight difference is going to be statistically significant, but it's not going to be clinically significant. And very few studies have actually examined sex differences in door-to-needle times. All right, so now let's talk about outcome. And again, there have been multiple studies that are interested in the sex by treatment interaction. And this is the interaction p-value here on the side. And you'll see that none of these are less than 0.05. So the bottom line is that when you have a randomized controlled trial and you take away a bias for treatment, that's what randomization is about. You take somebody and you just pick a number out of a hat and they get one treatment versus the other. And so when you have that kind of control in your study design, there's really no difference in treatment or the response to treatment by sex. And then when you look at endovascular therapy, these are relatively recent trials. There's not a lot of data out there. And we're interested in the eligibility to have an endovascular therapy based on the evidence of large vessel occlusion, and then the access and the outcomes. And so what we found here is that when you look at large vessel occlusion, 11% of a large population here with ischemic stroke had an LVO. And I think that's pretty common across most studies in the US. And another study of CT angiograms within 24 hours of symptom onset found that women were more likely to have an intracranial large vessel occlusion, but there was no difference in lesion volume. And then another large international registry showed that of patients receiving reperfusion therapies, more women had anterior large vessel occlusions, which could have to do with having a higher prevalence of atrial fibrillation. So that can lead to MCA strokes more likely than other mechanisms, mechanisms or causes of stroke. Now, are there sex differences in endovascular therapy and outcome? There's basically the nationwide inpatient sample showed that women were less likely than men to get this. But again, this precedes our current data on randomized controlled trials. So if we look at those, Mr. Clean had 500 patients, 208 women. There was a suggestion of a difference in mortality in women versus men. Now this has been looked at in a pooled analysis of all of the major randomized controlled trials of endovascular therapy. And this is a lot, this is a large number of patients, and they found no significant difference in outcome in men versus women. And of course, they controlled for all the confounders that we know are important. And it's also randomized, so there's not a bias in terms of who gets the treatment. So in summary, sex differences we know were identified in a number of important aspects of the acute stroke evaluation, and that is that women have more non-traditional signs and symptoms. They're more likely to have mimics, and they're more likely to have longer door-to-imaging times. So I think all of these three factors are linked. And it really comes down to being able to identify stroke in women in the ED when they may not have all of the traditional signs present. Now, one thing I'll mention, I didn't show you a slide of this, but there has been really great work looking at the traditional stroke symptoms and signs between men and women, and they're the same. That's the good news, is that if somebody comes in with a hemiparesis, that's equally likely to be significant in both men and women. Okay, so the traditional signs of stroke and symptoms are really similar in men and women. It's just that women might have some other interesting things going along with their symptoms that could sort of derail the acute stroke evaluation. And then the areas where there's probably uncertain or probably non-significant differences is the use of EMS. Knowledge of stroke signs and symptoms, I didn't show you that data, but there was really no major difference in the awareness between men and women. Eligibility for TPA and use of TPA, similar. Door-to-needle times, we don't have major differences there. Treatment with IV TPA or endovascular treatment, and then outcomes after TPA. And this is based on large, pooled, randomized controlled trials. And that's the best way to be able to assess for subtle differences, and we still didn't find any. So our conclusion was that women were more likely to have non-traditional stroke signs and symptoms, stroke mimics, and longer door-to-imaging times, no substantial or consistent differences in some of the pre-hospital aspects of stroke care, the eligibility for or access to thrombolytic or thrombectomy therapy, and then outcomes after either treatment. And again, major confounders, really common theme here is age, pre-stroke function, and comorbidities. So what are the things that we should do in the future to alleviate or ameliorate some of these differences? Some of the questions that still need to be answered relate to the pre-hospital evaluation. We should assess and understand the infrequent use of EMS in men and women, and investigate sex differences and factors that might influence use of EMS services, such as living status, living alone versus living with family or other caregivers. And then stroke knowledge, there's still more to be done about that to educate both men and women. And if there are, some women may be reluctant to act on their stroke symptoms, that's something we need to work on as well. And then the clinical presentation, understanding more about the physiologic reasons for the additional stroke symptoms, non-traditional stroke symptoms that women might have. Maybe it's related to their comorbidities. They have fatigue because they have osteoarthritis, and that's kind of overlaying on top of the acute stroke symptoms. Time to brain imaging, again, this is really work that needs to be done in the emergency department to educate our emergency medicine providers about the potential for delays in the ED. And then timing and use of CT is also important. TPA eligibility, there's probably some work that we still need to do in this area, although I think that the data that I showed you showed that there are really differences that make sense. If women are coming in later, then they're going to have less likely to be eligible. I think it's really important here, though, to make sure that we're adequately treating blood pressure so that women who may be in the window but have hypertension get that treated so that they can still get TPA or endovascular treatment. And then door-to-needle times, everybody's working on this. This is like across the country. Everybody wants to get their door-to-needle times as fast as possible. And so there's all kinds of evaluations that we need to do for that, and quality improvement. Endovascular treatment, we have more studies that will probably be coming out soon, especially related to DAWN and DEFUSE, which are the two trials showing that we have an extended window for select patients. And so is there a difference between men and women in that scenario? And that's something that we'll probably see in the literature soon. So one of the other things I just want to point out is this is kind of goes along with sex as a biological variable, is that in our prior studies of NIH-funded stroke prevention trials, women made up less than half of the subjects, even though they make up half of the stroke population. There was a lower participation of women in stroke prevention trials. That limits the generalization of results. And then now NIH does require the inclusion of women and minorities in grant applications, and you actually have to say that you're going to enroll X% women or X% underrepresented minorities. But this is showing you the representation in some of our landmark clinical trials for stroke, and you'll see that most of these percentages in parentheses are under 35% in terms of carotid endarterectomy. And then in antiplatelet trials, the only one where you saw greater than 50% women was in the AAA SPS, and this was the African American antiplatelet study, prevention study, and there were primarily African American women that were enrolled in this trial, and that's why you have a higher percentage there. So still a lot of work to be done to understand how we can engage women in participating in clinical trials, and also encouraging strategies to target these populations. They're doing that now with the CREST-2 trial, which is a comparison of intensive medical management versus carotid endarterectomy or carotid stenting plus medical management. And in this study, they're probably too late, but they did bring in a committee that is working on trying to improve the minority and women enrollment. So this is just a page from the publication by the woman who is the Office of Research and Women's Health Director at NIH, and she basically put out a guideline for how to apply sex as a biological variable to policy to research and clinical care. It's a fantastic article, and I found that if people actually read that, they'd probably have their grant applications positively reviewed from this aspect of their application. And then just to remind you all, maybe you remember this from a few years ago when we found out that Zolpidem, or Ambien, was actually causing all kinds of problems in women who were taking this. So they would take it at night to get to sleep. The next day they would have problems driving, they'd be in accidents. And this was phase 4, or kind of the post approval phase, monitoring phase of complications and side effects. And women were actually having significant side effects. They actually saw this in the data in the FDA, but didn't change the dose. And so this is one of the reasons why NIH and a lot of other groups were interested in looking at sex as a biological variable, because it could lead to major problems with post-trial use of a new medication. And so this is from a researcher at UC Irvine who said, the assumption we're making that it really doesn't matter sex is not a valid assumption. It may not matter. It may matter hugely. But the way we're doing business, the way we're assessing sex differences in research has to change. So the future implications are that we think sex differences in stroke may be less prevalent than previously reported, and that's because there is a lack of adjustment for these important factors: age, pre-stroke function, and comorbidities. And these clinically significant differences are found in stroke risk with diabetes and atrial fibrillation, as well as stroke presentation and door to imaging times. And that we need further well-designed studies that are going to identify sex differences that potentially could influence treatment. Right now, we're not saying that there needs to be any difference in the approach to treating men and women with stroke, but we do need to recognize these non-traditional stroke symptoms. So I'm going to stop there. I'd be happy to answer any questions, and thank you so much for your attention. Yeah, there's a question. Are you talking about a door to needle time, or are you talking about stroke onset to treatment time? It's still 3 hours, yeah, but really it as soon as possible. Time is brain, so we really want to treat as soon as possible. And this is why you'll see in the literature they're using mobile stroke units, so they bring the CT scanner and the TPA to the patient in the field, and are able to decrease that time even further. But yeah, that's a great question. 3 hours, but there's also a window up to 4.5 hours for TPA. For endovascular therapy, it's 24 hours now, if patients have the right imaging criteria. Any other questions? Yes, yes. Yeah, so the question is about ways to reduce the delays in evaluating mimics or a strategy. And one of the things we found in our review on that topic was that there probably should be more MRIs done acutely. That would help us tremendously. We're honestly humbled every day by patients that come in with a symptom that we're like, no, I don't know. Could be a stroke, maybe not. I'm not sure, I'm convinced. And you do the MRI and sure enough there is a stroke. So the problem is getting MRIs in that acute situation if we're considering TPA. There have been a few times we've been able to get MRI quickly enough to still give TPA. That's a pretty rare occurrence. At our institution, we just don't have the capability of getting MRIs acutely, and the guidelines don't say that that's necessary. So until there's kind of an incentive to get MRIs quickly, I'm not sure that that's going to be part of standard practice. But that would be the way to alleviate the ambiguity of mimic versus a real stroke. And there are centers across the country that have MRIs in their emergency department. They're like owned by the neurology department. And they can get MRIs at Mass General in just a few minutes. They can get MRIs at Johns Hopkins in just a few minutes. So that's just not been something that we've been able to do. You think about, you have to have all the magnet protection and all that kind of, you have to have a special building really to house an MRI and an ED. So there's a lot of money that would go into that and that change in practice. But that's a great question. Any